Well, good morning. If I could get everyone to take their seats, we'll get started with our board meeting. Welcome, everyone, and thank you for joining the public session of the National eHealth Collaborative Board of Directors meeting today, June 2nd, 2009. I am Dr. John Tooker. I'm chair of the National eHealth Collaborative Board of Directors. In addition to those of you who are kind to join us here today, we also have quite a number listening on the meeting via our phones. I would appreciate it if we could keep the extra noise to a minimum, and for the board of directors, a reminder to please speak directly into the microphones now. You may notice, it's hard not to notice, there's a video camera right there. We'll be taping the panel discussions this morning and posting the recording tomorrow on our website at www.nationalehealth.org. As we begin this morning's meeting, I also want to remind everybody on the phone that all the presentations our board will see here are available on the website, nationalehealth.org. For those of you in the room wanting to follow along or take notes, copies of the presentations are available on the registration table just outside the room. And one last reminder before we get started, at the end of this morning's session, as is our tradition, we will have a public comment period. On the table out front, you'll find a comment request card. In order to make the comment period run smoothly and get as much participation as we can in the short time that we'll have available, we ask that anyone wishing to speak please fill out one of those cards and hand it to one of our staff before the end of the second panel. I'll then call each of you to the microphone in the order that your cards are received. And I'd like to point out our key staff who will be assisting in the comment period. The first is Merritt McGinley, who is our communications director, and Ernest Clover, who is our executive assistant. And I don't see either one of them, but they're here. If anyone on the phone wishes to make a comment, please do not hesitate to email us at info@nationalehealth.org or via our website, nationalehealth.org, at any time during the meeting now. Well, we have a great agenda for you this morning, so we'll get right to it. We have three separate presentations. The first is from a very good friend of NEHIC, John Halamka, Dr. John Halamka, who is the chair of the Health Information Technology Standards Panel. And in just a moment, John is going to be talking about the activities of HITSP supporting the HITECH Act. Following that, we're going to have a panel discussion on the critical success factors for health information technology adoption in small physician practices where most of healthcare takes place in this country, with experience from the field. And one of our board members, Paul Tang, will be moderating that panel. That will be followed then by a consumer panel discussion, the demand pull for electronic health record adoption, is it possible? And we're very pleased to have guest panelists here for that panel as well, and that will be moderated by Steve Finley, also a member of our board now. So it's my great pleasure to turn the mic over to John Halamka, who will talk to us about HITSP activities supporting the HITECH Act. John?
Well, thanks very much, and good morning. It's always a pleasure to present to the National eHealth Collaborative. Over the course of the last couple of months, HITSP has had to transition all of its activities away from what were the use cases or value cases approach to now focusing on the 8 elements that are the focus of ARA and meaningful use. Now, none of us in the room quite yet have an idea what meaningful use precisely will be, so as Jonathan Perlin and I have discussed as part of the HIT Standards Committee, our job is to skate to where the puck will be. And so I'd like to present to you is how HITSP has completely realigned all its activities now in support of meaningful use and the quality and efficiency that we expect we'll get out of ARA. So we know that the American Recovery and Reinvestment Act really changed the game. That is, it is now requiring a new set of constructs. The HIT Policy Committee, the HIT Standards Committee, there are work groups associated with these committees, and the role of HITSP has been to support the activities of these committees and work groups. Everything is happening in an extraordinarily accelerated time frame. So we recognize that there's been work done over the last 4 years that's very good work and can be leveraged going forward. Now, that work is not without issues. A lot of the documentation that HITSP has produced over the last 4 years is dense. It's several thousand pages of use case specific work. So our job, as I'll show you, is how to repurpose all the harmonization that we've done with 600 different stakeholder organizations and now make it extraordinarily accessible and very easy to use when meaningful use is fully defined. There are 8 areas of focus, and I'm sure all of you have read the American Recovery and Reinvestment Act in detail, so I don't need to perseverate on these. But clearly, we want standards that are going to protect privacy and security, support the notion of healthcare information exchange, regional and national. That we want standards that will support not silos of data, but interoperable EHRs for every American by 2014. We want to make sure we have standards supporting disclosure. A quick comment. Disclosure is different than audit. So if I were to go look up Lori's record, of course I'd be fired, but there would be an audit trail suggesting that I did that. However, if I looked up her record for the purpose of disclosing it to the Social Security Administration in support of a disability application, that actually wouldn't show on any audit trail. It's a disclosure I made, different technical process. So we have to make sure we have standards to support that. We have to ensure that we are supporting standards for the measurement of quality and all the work the NQF and HITECH has done. We need to make sure that we are using those encryption technologies that render information unreadable and unusable. We need to make sure that we are collecting patient demographic data, including race, ethnicity, primary language, education. And we need to ensure that we're supporting the technologies to protect vulnerable populations, such as children. So those are our 8 marching orders. How have we organized ourselves over the last 60 days to deal with meaningful use in those 8 marching orders? Rather than using the standard HITSP technical committees, we have established 5 Tiger teams. And these Tiger teams are specifically producing artifacts that are going to be electronically published in time for the HIT Standards Committee and its work groups and the HIT Policy Committee to, during the course of this summer, begin to utilize as we all march toward an interim final rule to be done by December 31st of 2009. So specifically, we have a group working on what we call an EHR-centric interoperability specification. Now, what is an EHR-centric interoperability specification? In the past, we had use cases or value cases. And what the idea was is, oh, if you want to do this particular set of actions with these particular actors and events, here's a book. It's a cookbook. It tells you exactly what to do. Well, the EHR and the meaningful use of the EHR is probably going to have a lot of functions that cross thousands of use cases or value cases. In fact, one could argue that the use case process, though a great construct to get us started, maybe actually would never be finished because there would always be new use cases. So instead, we've reorganized our work around the functional aspects of what an EHR is and does. So that any one of you, if you said, oh, I have this really great idea for a new use case, yeah, we're going to actually monitor emergency departments and ambulatory records for symptoms of H1N1 flu. Well, who could have ever presumed that would have been a use case 6 months ago? Well, you'll have the components, the functions, the data elements that would be necessary to do that. And in fact, you could assemble the necessary data exchange on the fly using a set of predefined capabilities. And I'll show you how, at the moment, we've defined meaningful use of an EHR as 22 separate capabilities of data exchange. It makes it very, very reusable. Now, we also need to ensure we have secure data exchange, common data transport, because again, those use cases tended to look at various, oh, you've got a public health agency and you've got a hospital. How should they communicate one to another? So it's not only about the content, but it's about secure transmission across various actors. So we've got a whole group working on that common data transport and architecture. Working with the NQF and its HITECH activities, we have a group working on quality measurement. And the way I think about the world is the NQF and the metrics or measures offering organizations underneath it tell us what to measure, and now with the work of HITECH, how to describe what we've measured. And HITSP helps figuring out how to transmit those measures so they can go from a doctor's office to a quality repository or from a hospital to CMS, all of the actors who actually want to take physical data. And that's the way we've tried to divide this up. So you'll see this 108-member group is really working on those data standards for content and vocabulary to transmit information. Value sets are increasingly important. That is, how does one describe gender in an ambiguous way? How does one describe a problem list in an ambiguous way? Now, e-patient Dave is going to be chatting with you later, and he and I are good friends from Boston, and we've worked together on value sets for PHRs and EHRs to communicate clinical concepts in an unambiguous way. HITSP is now embracing a whole set of problem list, medication list, lab units of measure, gender, set of value sets. We've got a team working on that. How do we ensure security and privacy is always protected? And these are all those encryption standards that I described were part of ARA's marching orders. Now, although it was not a specific charge in ARA, we did have a parallel set of work going on to support clinical research and clinical trials. So although we've placed on hold many of the other activities of HITSP, we did continue that particular thread. We had a very good set of stakeholders who were funding that activity, and it was done in parallel with these other 5 Tiger teams. It was not a distraction, so we felt we could keep on with that particular set of work. So just to show you how we have aligned all of our work, you can see on these particular tables, we've put in columns that identify all of the various 8 goals of ARA and then all of the Tiger teams. And so you can see that we've identified appropriate teams to get all of this work done and deliver by July 15th what is necessary to support ARA. So we're doing this because we believe, since ARA has changed the world, that we will, as an organization, now support committees, support ARA, and, of course, as NAHIC has advice for us, we look forward to your input as we get to implementation and support for EHR and PHR. I hope what you'll see today is that we have really changed from what we used to be to something a bit more nimble and supportive of the current administration. A couple of slides for you. So what we did in the past, which was good, is we assembled stakeholders. 600 different stakeholders from government, from academia, from industry, from standards development organizations, and we were able to constrain a lot of the variability in standards. I mean, there were 700 initial standards proposed. We've been winnowing that down to now a couple of dozen, so that's good. But what we produced, as I mentioned earlier, was a bit dense, very lengthy documentation. That documentation had many layers. It pointed to many products of standards development organizations. If you wanted a novel application, it was a little hard to develop that on your own. So our challenge is we recognize the need to do electronic publishing, to move to more of a services and capabilities concept, and effectively make it so that any user could assemble from our electronic artifacts whatever standards they needed to support their particular data exchange operations. So we've moved from the interoperability specification, that cookbook, to a set of published web services. And the idea that you can now state the meaningful use the data exchange necessary in EHRs as a set of service constructs. And let me explain in some detail what I mean by service constructs. So I don't have any inside information as to what meaningful use will actually be defined as, but here are the 22 kinds of data exchanges we think are meaningfully useful. So there's a whole body of work around what I'll call clinical operations.